EKG findings of hypothermia, stuff you'll see on the monitor, the rhythm strip, you know, with a very hypothermic patient that you won't see otherwise, you normally won't see otherwise. Okay, so the strict definition of hypothermia, it's a core body temperature below 95 degrees Fahrenheit. You know, it's the, I never think in Celsius, I've tried for years, I always think in Fahrenheit. So, but it's 35 degrees Celsius, but 95 degrees Fahrenheit. You know, normally the body temperature is anywhere between 97 and 99, so below 95. In mild hypothermia, the core body temperature is anywhere between 89.5 to 95. In severe hypothermia, the core body temperature gets below 89 degrees, or 89.5. And then once you start to get below 86 degrees Fahrenheit, that's when you start developing cardiac arrhythmias, VFib, very slow AFib, asystole. All right. So we'll start with mild hypothermia. Again, this is your core body temperature between 90 to 95. And we call this the metabolic excitation phase of hypothermia. What that means is your body is compensating for the, you know, you're losing the core body temperature. Your heart rate's going up, your blood pressure's going up, you're breathing faster. Your body's doing what it can to try to rev up its metabolic rate to try to create heat. You will start shivering, uncontrollable shivering. And you may get a little bit confused, but with mild hypothermia, you can still hold a conversation. I mean, you can still talk to the person, they'll talk back to you. And you'll get uncoordinated, fine movements, picking up things, trying to write. I mean, it's just going to be very, very difficult, even in mild hypothermia. So in this phase, again, your compensatory mechanisms, they've not failed yet. They're in overdrive. They're trying to keep you warm. You're still conscious. You're still talking. You're shivering. I think most of us probably in some situation, right, where you're so cold you can't stop shaking. Because I know I have. I think you've had mild hypothermia. You've been in that kind of situation.
What is the urge to urinate?
So when you get cold, what happens is all of your blood gets shunted to the core. So the blood vessels of the arms and the legs constrict, and you get a massive shunting of fluid and blood to your core. Your kidneys are part of your core. So all of a sudden your kidneys see this massive increase of flow. And when your kidneys see all this additional fluid and flow, it creates a whole lot more urine because you're getting a lot more flow through the kidneys. All that fluid in your body is getting shunted, like I said, towards the core. It's trying to say, I will forego your arms and legs to try to save your brain and heart. That's basically what your body's doing. So it's shutting off blood flow to the arms and legs. All that blood going to the core, increased urinary or kidney filtration, increased urine output. That's basically what it's doing.
Okay, thanks.
Yeah. So, like I said, this little mannequin, confusion, mild confusion. We're not talking like real lethargic or unconscious. Mild confusion, lack of coordination, shivering, whole body, or shivering. Okay, so the treatment. Like I said, very important, shivering but talking to you. And from a hypothermia standpoint, these people are going to do fine. They're going to recover. As long as you can get them out of that environment, that cold environment, into a warmer one, anything you do, they're going to recover just fine. So typically just passive external rewarming measures, we'll go over those, is going to be sufficient. So most importantly, removing the patient from the cold environment and putting them into a warm environment. And that's usually enough. But other things you can do, actually it is important to remove wet clothes. If the person's wet, that's important to take off the wet clothes. And then try to prevent further heat loss by covering with a couple blankets. Kind of just all over the body, multiple blankets. This is optional. Again, they're going to do fine with just these above measures, but typically, I mean, I know you guys have those kind of what they call heat pads. So you can do, that's an example of an active external rewarming measure. So actually applying heat. That's optional with mild hypothermia like this. You're not going to hurt anybody by doing it. Putting warm packs in the groin, axilla, and the neck. It's common to have a low blood sugar in hypothermia. Again, your metabolic rate, it's in overdrive as your body's trying to create heat. That burns off a lot of sugar. You can actually have a low blood sugar that way. And it's not uncommon at least an environmental cause of hypothermia to have other traumatic injuries. So just assess them for other possible traumatic injuries.
What about warm fluids?
So, do you guys have a way of giving warm fluids in the truck? I'm just curious. You do? Yeah.
Pads, we put our fluid.
You put heat pads around the fluids? Okay. Yeah, you can do that. It won't hurt anything. That's fine. In the ER, we'll get to it here in a second, but with severe hypothermia, that's one of the mainstays of treatment is warm fluids. And it's one of those things, almost the warmer the better. Ideally, up to 145 degrees Fahrenheit fluids. Usually our hot line can't quite get that high, so I usually say just crank it up as high as it can go. So yeah, some warm packs around the fluids, you're not going to hurt anything doing that. That's not a bad idea. Again, that would be an example of active internal rewarming, which we're going to get to in a second. Probably not necessary for mild hypothermia, but again, you're not going to hurt anything. If you want to do that, that's fine. Okay, so severe hypothermia, this is where things get dangerous when the core body temperature gets below 90 degrees Fahrenheit. We call this the metabolic slowing phase. Basically what that means is your body's compensatory measures of increasing your heart rate, increasing your blood pressure, increasing your breathing, it's failed. It's not working. And now your body's basically shutting down. So your heart rate goes down. Your breathing slows dramatically. Your blood pressure starts to drop. You're no longer shivering. Again, it's failed. You're not shivering anymore. You are either lethargic, minimally responsive, or just flat out unconscious. Typically, your pupils are dilated and very sluggish to reactive to any kind of light. This is a true medical emergency. This person with these kind of symptoms will die if measures aren't taken quickly to save them. So, I try to find a good picture of a severely hypothermic patients, but that's not a bad look. I've only seen maybe 6 or 7 ever, but that's basically what they look like. Just very pale blue and cold and cold. That's kind of a busy slide, but so pre-hospital treatment for severe hypothermia. You're still going to do these passive external rewarming measures. So by far always going to be the most important. Remove them from the cold environment, place them in a warm environment. Remove wet clothes. Cover them with a blanket. With severe hypothermia, they're usually hypotensive, so lay them supine. Don't set them up. And then the active external rewarming, like we talked about earlier, that's warm packs in the groin, axilla, neck, chest, abdomen. You got to be careful with these folks. With severe hypothermia, the heart is very irritable. It doesn't take much to flip it into ventricular fibrillation if they're not there already. It does not take much. So try not to jostle, I guess, too much. I don't know, that's what the text would say. So just try to be gentle with them. And really, you should only be treating life-threatening arrhythmias with severe hypothermia. So that's being VFib and asystole. If you have a very slow sinus rhythm, heart rate at 30, something like that, if you can feel a pulse, even if it's a slow sinus rhythm of 20 or 30, it's not something you want to give atropine to. It's not something you want to do external pacing with. You kind of want to let, as the body rewarms, that will fix itself. So this is somebody you don't want to give those kind of medicines to as long as they have a pulse. You don't want to give those kind of medicines to them or treatments with the pacing, because it could further irritate the heart, and you could go from a sinus bradycardia with a pulse to ventricular fibrillation. Again, the heart's very irritable when it's this cold. No one really knows why, by the way. No one knows why the heart gets so irritable and flips into VFib, but it does when it gets cold. So, yeah, we talked about that. Don't place hypothermic patients on pacers. When you're this cold, atropine rarely works anyway. It just, again, there's no why. Just the heart doesn't respond when the temperature gets below 86 degrees Fahrenheit. And you don't want to treat hypotension with the dopamine. Again, that hypotension fluid, sure, and warm fluids, like you said, that's great. But that hypotension will resolve as well as the body rewarms. The dopamine may be just enough to irritate the heart to the point where they go into ventricular fibrillation. So IV access, give fluid, of course, put them on the monitor, EKG, oxygen, like we talked about, check an AccuCheck. If there's a concern that there's drugs involved as well, specifically opiates, with opiate overdoses, it's not uncommon for your body temperature to drop, core body temperature to drop. So there's a concern that they've overdosed. That is one thing you should give is Narcan, because it will actually help to raise their temperature a little bit if they're on narcotics as well. One thing to not do that instinctually you think would help is you don't want to rub the extremities with your hands. You don't want to take their arm or leg and kind of do one of these things with them. The reason being is that skin probably already has severe frostbite damage to it. You do that and you're going to create, well, first of all, you're not going to help anything. And then secondly, you're going to just further damage the skin to the point where it may not heal if they do survive. So you're not going to help anything by doing that, by trying to rub their extremities or doing one of these numbers. And there's a good potential you can make things worse. Not to mention, like I said, you don't want to jostle these people around. So the last thing you want to be doing is shaking them around. Looking to beat it. Any questions about that slide? Got more coming. So in the emergency department, what you'll see happen with a severely hypothermic patient, and sometimes even a mild hypothermia, they'll still get the bear hugger out, which is fine. So a bear hugger, everyone's seen that before, right? It's like this big plastic inflatable sheet that's filled with hot air that goes around the tissue. But anyway, the bear hugger is a good example, another example of active external rewarming. So just like those hot packs you put in the axilla, the neck, and the groin, that's an example of active external rewarming. So is a bear hugger. Again, it's external to the patient. It's a heat source that's trying to rewarm them up. You'll see every ER doctor approach things differently, but there is a true thing called core temperature after drop. That's basically, when I get people that have severe hypothermia in the ER, I try to apply that external heat just to their core, so chest, neck, head, belly. I try to leave their arms and legs out, because the reason being is, really I'm not worried so much about your arms and legs at that point in time. I'm more worried about your heart going into VFib and warming up your core, warming up your heart basically. If you apply heat to the arms and legs, you'll warm them up, but what will happen is those blood vessels will dilate, and then your core will get this rush of cold blood to it, and you'll actually see a drop in your core temperature. I watched a neat video on it where they had a bladder thermometer in a patient, and they were rewarming the patient, and they had the bear hugger kind of across the whole body, and you actually saw the temperature drop by about 1 degree Celsius before it started rising again. And it was that after drop phenomenon where the extremities, the blood vessels are dilating, and this big surge of cold blood going to the core. So active core rewarming. So an example like you talked about was warming up the fluids. So warm IV fluids, we have something called the hotline. I think I meant to look and check. I think it warms fluids up to 113 degrees Fahrenheit. Again, I think the warmer the better, and I read preferably 145 degrees Fahrenheit would be about right to put them on. And then either you give them normal saline or D5 normal saline. I prefer D5 just because, again, your body's gone through a massive metabolic excitation phase before it got to this slowing phase. So usually your body's used up a lot of sugar. So I usually give just a little bit of sugar in my fluid, D5 normal saline. Warm humidified oxygen, that's another way to help kind of rewarm the core. These are called the non-invasive ways. So you're not having to do any kind of real procedures to do this. Humidified oxygen, warm IV fluids. And then you've got your invasive measures. I've never seen these. I've read about them. I think if I was going to do one, I'd do the thoracic lavage, which is basically you put 2 chest tubes in somebody on their left side, because again your heart's more on the left. And you put one in the 3rd intercostal space and one in the 6th intercostal space. And on the third intercostal space, you're dumping in warm fluids, and the tube coming out of the sixth, the fluid's draining out of that tube. So it's kind of like this infusion and outflow of warm fluids, and you're trying to bathe the heart basically in warm fluids to try to warm it up. So I think if I was going to do one, that's what I would do, because I'm aiming to try to warm up the heart. Peritoneal lavage is basically putting a catheter into the abdominal cavity, and again, just pouring in warm fluid to bathe the intestines and all the organs in your abdomen, and then having a second catheter drain out that fluid. So kind of like the same idea with the chest tube, it's just in the belly instead. And then the most preferable way, I'm pretty sure we don't have this ability at Plymouth Regional, is cardiopulmonary bypass, where you actually get them on a heart bypass machine. The cold blood runs through the perfusion machine, and then it returns warm blood back. That's the quickest way to warm somebody up in severe hypothermia. So again, I've seen all of the above. I've done all of the above before. I've never done this one. It's the one that if I had a severe hypothermic patient that was coding or going in and out of EFib, that's probably what I would do, is a closed thoracic lavage. Any questions about those? Again, that's stuff you'll see in the ER most likely with these severe hypothermic patients. So hypothermia in the heart, that's the big one. That's what kills people. Your heart goes into a fatal arrhythmia. Like I said before, we don't really know why the heart becomes irritable and fibrillates, but it does, especially when you get, like I said, below like 86 degrees Fahrenheit. And you'll see, this is kind of what you'll see with the heart rhythm as hypothermia worsens. Like I said, with mild hypothermia, you have this excitation phase. You have a sinus tachycardia, typically, when you're mildly hypothermic. As you start to progress to becoming more severely hypothermic, your heart rate slows down. Again, we call that the metabolic slowing phase. So slow heart rate, low blood pressure, slow breathing. That sinus bradycardia, it can jump to VFib, it can jump to asystole, it can start to go into a slow atrial fibrillation. So now it's not a regular bradycardia, it's kind of an irregular AFib that's slow. But again, it doesn't always follow this exact progression. Sometimes it can jump from here to here or here to here. Heart's very irritable. Yeah, and then we'll kind of show you what an Osborne wave is. There's an EKG finding that's, you really only see these kind of J waves, Osborne waves, in a really hypothermic heart. I think in the next slide or two, there's examples of J waves. So, I'll see if I can hold my hand steady. Right there is an example of a J wave. Right there, there. So you've got the QRS complex, and then after the QRS complex, you've got another spike, and that's the J wave. Okay. You will typically see J waves like this in combination with a very slow heart rate. This heart rate, 2, 3, 4, 5, 6, is about 50. Yeah, this heart rate's about 50. So again, this is a hypothermic patient on the severe side, because again, you're past that excitation phase. You're now in this slowing phase. So this is a severely hypothermic patient. Again, with these, you only really see these with hypothermia, these J waves. You also get very long intervals. So like your QT interval, so the end of your QRS complex to the end of the T wave, really long. You get kind of long sloping T waves too. So everything just kind of comes elongated out. This is one, it's not perfect, but I think this is an example of a slow AFib. It's not perfect. I wish I had a rhythm strip at the bottom, I can tell you for sure. But again, you still see these Osborne waves. There would be an example of an Osborne J wave. There's an example. That's a good example of an Osborne J wave. And it looks irregular too, and I'm pretty sure this is a slow AFib. Yeah, especially if you're an AVR, you can kind of tell it's an irregular thing. So. Alright, so what we worry about with severely hypothermic patients is, again, they can easily go into cardiac arrest. And the management of a hypothermic cardiac arrest, it's a little bit different than your traditional ACLS, VFib, or asystole. Just a little bit, for the most part, it's the same. You're usually going to see this happen when you get below 86 degrees Fahrenheit, like we said. If they're not on the monitor, if you approach the severely hypothermic patient and you're thinking, man, they're dead, they don't have a pulse. They must be in either asystole or VFib, and they're not on the monitor yet. It's different. In traditional ACLS, you kind of feel for a pulse for maybe 4 or 5 seconds, and if you don't feel one, then you start CPR. It's different in hypothermia. You want to feel for a pulse for a good 30 to 45 seconds before you determine, okay, they truly don't have a pulse. Because they may have a very slow sinus rhythm. And if they have a very slow sinus rhythm, you don't want to start beating on their chest because you don't want to flip them into VFib. Okay? So if they're not on the monitor yet, and you get to them and you're like, I think they're in cardiac arrest and they're severely hypothermic, give it more time. Give it about 30 to 45 seconds to feel for that pulse. If after 30 to 45 seconds you're not feeling a pulse, then start compressions. Okay, so that's a little bit different than your traditional ACLS stuff. Alright, so with VFib specifically, the recommendation is if your temperature, and you won't know this is the problem, you're not going to know this because you don't have the core thermometers on the trucks, but the recommendation is trying to shock up to 3 times with severe hypothermia. If you see VFib, if that's unsuccessful, then really no further shocks until you've gotten the body above 86 degrees Fahrenheit. So, you know, if your core body temperature is 82, 83, 84, you've tried shocking them 3 times and there's been no resolution to VFib, they're still in VFib, then the recommendation is warm them up first before trying again. Because the idea is you want to keep doing the compressions, and the delay in trying to shock, it's obviously not working, and it's probably not going to work until they're warmed up. So you're better off just continuing compressions. Magnesium has a role. I mean, it has a role in VFib anyway, but especially in hypothermia. There's been news reports that a couple grams of magnesium IV has been shown to convert hypothermic VFib. So give them a couple grams of IV magnesium. Other cardiac drugs, again, you're not going to be faulted for giving these kind of drugs. It's just they're probably not going to work. But other cardiac drugs, epinephrine, atropine, typically if I'm seeing the patient and I've got their core temperature, I'm really not using them until their core temp gets above 30. Or if I do use them, it's not the traditional manner. I'll give a dose of epi and I'll wait 10 minutes, 15 minutes before I'll give another one. Because it's just not likely going to do anything. It's not going to work. When your heart's that cold, it just doesn't respond to these kind of medicines. Yeah, your real focus should be concentrating on chest compressions and trying to remold the patient. That's how you're going to help them the most if you're severely hypothermic and you're in VFib system. No one's going to fault you for continuing to shock. No one's going to fault you for giving epinephrine or atropine or whatever you want to give. I'm just telling you, if they're that cold, it's probably not going to work. With asystole, again, like we talked about, be sure they're truly in asystole because you can have a long pause before beats, and you really have to be kind of diligent. Is this a slow PEA or did I actually feel a pulse? If you feel a pulse, then again, you don't want to do compressions on these people. You don't want to be giving them a bunch of cardiac drugs if you can feel a pulse. And you know, there's an old saying, "You're not dead until you're warm and dead." That's kind of true, but you know, typically we will continue CPR until you get the temperature at least above 90. That's typically the goal. Now, there are ways around that. If you have a severely hypothermic patient, I think like 4 or 5 years ago, we had an unfortunate teenager who fell into a lake here in town. Him and I think his 2 buddies, and 2 of the buddies got rescued out of the water pretty quickly. The 3rd was underwater for over an hour, and fell through the ice underwater. And so not only was he severely hypothermic, but he had drowned. I mean, just pond water, just all inside of his lungs. He was so cold that when we tried to start an IV, it was like crunch, 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 because literally his blood had frozen. And when we put in the catheter, no urine initially came out because it had frozen in his bladder. So if you check, like, if something like that, they're not going to come back. But the way you can know for sure is if you check a random potassium level. This isn't anything you guys are ever going to need to worry about, just to let you know. Typically with a patient like that, once I'm able to get a blood sample, I'll check a potassium level. If it's greater than 10, they're dead. So that's kind of a way to, because if you were to try to rewarm somebody like that, it would take hours upon hours upon hours. But if you've got a potassium greater than 10, or if your chest is so frozen that you can't compress it because it is so frozen, you're done. So that teenager unfortunately didn't make it. It was just frozen solid. But typically with these people, we try to warm them up before we declare them deceased. Okay, so I got a neat video that kind of reinforces the difference between mild and severe hypothermia. Let's go play it for you.
In my mind, there are simply two kinds of hypothermia that we need to be aware of when we're in the field. One is severe, and one is mild. So what's the difference, and why does it matter? Well, it matters because that for mild hypothermia, the treatment is simple. In fact, you want the treatment? Here it is. Everything your mother taught you to do when people get cold is fun. Just do whatever your mother taught you. So that means if you want to give somebody some hot chocolate, give them hot chocolate. You want to put them in a hot tub. You want to set them down next to a fire. Whatever. It doesn't matter. You're not going to kill them. So just do whatever you need to do. The problem is with severe hypothermia. And a lot of people get the two entities confused. So with mild hypothermia, all of our organ systems compensate pretty well. So our liver works well, our heart works well, our lungs work well, our brains work well, everything continues to work pretty well. The problem is with severe hypothermia, where all of our organ systems begin to decompensate. And the biggest problem is the hypothermic heart, which has all sorts of trouble. And in fact, a friend of mine used to say the hypothermic heart is like a mousetrap waiting to, and that is fibrillation. And ventricular fibrillation is not a good thing. The heart just looks like a bunch of worms or crawling. There's no purposeful contraction. So the problem with the hypothermic heart is blood is cold, it's more viscous, we third space, meaning blood goes to places that it shouldn't, and contractility goes down, stroke volume goes down, heart rate goes down. The product of those two things is cardiac output is reduced, and the actual conduction fibers of the heart and the myocardium itself, the heart muscle, cools to a point where it's not very effective. And what this results in is all sorts of cardiac issues. So how do you tell the difference between a severe hypothermic patient and mild? Well, the patient that has severe hypothermia will be out to lunch. So the patient that's shivering and saying, man, I'm really cold, that patient is mildly hypothermic. Now as a guide, I take those patients seriously. I worked as a river guide for many years, and a patient that's shivering one moment, 30 minutes later can be in deep trouble. So I take a shivering patient in the wilderness seriously, but a patient that's looking at you and talking coherently and shivering is not severely hypothermic. Patients that are severely hypothermic have core temperatures below 90 degrees Fahrenheit and are typically obtunded, which is the medical term for out to lunch. They're not going to be coherent, or they're going to be unresponsive.
And that's it for hypothermia. Is there any questions about that we just discussed? Like I said, that audit review, next is got a couple of good hypothermia cases. Any questions about that before we go into the audit review? Yeah.
That's about that. Was you in the ER the night that they brought that kid in?
Yeah, it's a
The
good
ER
one for
doctor
you.
that night?
Yeah, it's a curveball for you. So go ahead and get started with this. There's 3 cases. 2 of them are hypothermia. All right. So at 1:05, EMS dispatched to a person ill. Arrived at the scene 4 minutes later. chief complaint, I don't know if they said hypothermia, but chief complaint hypothermia. Dispatched to the street or highway for a 25-year-old female complaining of being sick. She was found sitting on the ground in an alley about 5 feet from the road. A person went to pull into the alley and came within a foot from hitting her. Basically said she had been sitting there for several hours. She was alone, she was shivering, it was hard to get information from her. So events prior to the incident. She said she was at a friend's house all day today, left, had lost her phone, and had no way home. So alright, so already just now, she's shivering, and she's able to tell you she's at a friend's house all day today. She had lost her phone, had no way home. Is this patient mildly hypothermic or severely hypothermic? Yeah, why is she mildly hypothermic?
I shouldn't give you details about the day.
Yeah, and yeah, she can talk. She's shivering, so her body's compensatory mechanisms are still trying to work. I bet if you hooked her on the monitor, she'd be tachycardic. Her blood pressure is probably not low. If anything, it's probably high. She's probably breathing fast. So she's still compensating. Her body is still able to keep up with the heat loss, and she's compensating. So she's mildly hypothermic. Okay? At least that's most likely what's going on. So then, patient then began to walk around outside. She said she then fell onto some concrete. She has multiple abrasions to her body. It was hard to get information from her. We did look at her purse and found that there was a pipe for marijuana, along with a bag that had what looked like marijuana in it. She also had random pills in the bottom of her purse, a metal spoon, an empty pill bottle that looked to be old. She told us that all she took was a Xanax. So if this patient was severely hypothermic, this is one you definitely want to be giving Narcan to, okay? Because you're seeing all these red flags that there may be opiates on her. In this instance, you don't need to give Narcan. She's awake, she's talking to you, shivering and whatnot. But if she was severely hypothermic, this is one you'd be wanting to give Narcan. Oh, wow, that's not so let me see if I can just find any pertinent positives. So oriented to person, place, and time. Again, if you can be oriented to person, place, and time, you're mildly hypothermic. Just trying to see if there's anything really important. So abrasion to the mouth, abrasion to the top of hand, not sure which hand, with bruising, size of, right hand, with bruising, size of quarter. Abrasions, it looks like on the left lower extremity. And then a dime-sized bruise on the face, I think is what that says. Okay, so procedures. The spinal assessment's a good idea. I mean, there was a trauma, obviously some sort of trauma, so doing a spinal assessment makes sense. No deficits noted. Patient has lower born rate times 3, stable vital signs. Although once we got to the hospital, they did cord body temperature, and it was 93 degrees. So again, we're hypothermic. We're below 95, but we're not in that severe hypothermic category, which makes sense. It makes sense basically that our temperature's 93. Patient was very weak and sleepy. She fell asleep while en route to the ER, but woke up every time I asked her to. Again, there's a dime-sized bruise with no swelling above her left eye, and a knuckle-sized bruise at the top of her right hand near the knuckle. Took off her jacket to look for more injuries. There were none. Patient had no complaints of any other injuries. She does have a minor, less than a centimeter cut to the top lip, which did have some bleeding, but no other injuries to the mouth or face. So what kind of treatments would you do for this lady on the way in?
Give her a blanket.
Yeah. Make sure her clothes aren't wet, right? If her clothes are wet, get them off. Give her a blanket, just like you said. Again, if you want to do warm IV fluids, you don't have to. It's a mild hypothermia, but you can if you want to. I'd still recommend not doing any of the taking the arm and doing one of these. I'd still avoid that. In fact, I would just avoid that anytime, even with like frostbite or stuff. Just not a good. The skin doesn't like that if it's been damaged due to cold. It just doesn't typically like that. But yeah, just conservative measures. Making sure they're not wet clothes, getting them covered up. That goes a long way. Just getting them out of the cold environment is really what's going to help them most. She said she had fallen into the concrete. She has no neck or back pain. Once we got to the ER, we got her undressed, discovered an abrasion to the side of her lower leg, the size of a hand with bruising and swelling. Also an abrasion to that knee. On her left leg, there was a large contusion with bruising and swelling between the shin and the lower leg area. These injuries were not consistent with a simple fall. It is unknown how she got this, and the patient will not tell anyone. Full physical assessment was done. No other abnormalities were found. Once we had a patient in the ambulance, she was covered in blankets. I tried a warm pack again. Not necessary, but there's nothing wrong with it. Giving them warm packs in the groin, axilla, neck, it's not going to hurt anything. We had also turned the heat up as high as it would go, blowing it directly onto her. Once close to the hospital, the patient began to stop shivering. Patient was taken E9 where oral port and patient care was handed off to the nursing staff with no complication. Signature of patient was not obtained. Patient was under the bear hugger and sleeping. So it sounds like when she got to the ER, they started some active external rewarming measures. The medics had already started some of those with the packs. And again, probably not necessary to do the bear hugger. She was going to get better regardless, but at 93 degrees, she's still cold. I probably would too. I'd put her in the bear hugger just to get her temperature back up. Those are her vitals. Again, you'll notice that she's not bradycardic, so heart rate at 92, 20. She's breathing a little fast, not terrible, and blood pressure stable. So again, consistent with mild hypothermia. Okay. So that was a good example of mild hypothermia. Any questions or comments about her? I don't know where all the bruising came from. I'm sorry, I didn't look her up to see what all actually happened, but I basically just wanted to go over because it was a good case of mild hypothermia, and it kind of drives home the point of checking for their injuries. And I would recommend, again, her mental status was pretty good, so I'm sure her blood sugar was normal, but it wouldn't be a bad idea to check blood sugar on these kind of people just because their metabolism is in overdrive. It wouldn't be surprising if her sugar was a little low, but again, she was going to do fine regardless of what. As long as we got her out of that environment, she was going to do fine. Case number 2, syncope. All right, around 4:45, EMS was dispatched to unconscious fainting. Went en route a couple minutes later. Wow, right, really quick. I guess we've got a minute. Change in responsiveness. Yeah, that's pretty impressive. So dispatch went out 16:46 and got there 16:49. So anyway, change in responsiveness. 50-year-old female, weighing 109 kilos, complaining of she fainted. Patient was found on the floor, unresponsive. All right, so what's your first kind of thoughts? You go into a place, a residence, and you see somebody on the ground just unconscious. What's your first approach to the patient?
See if there's any consciousness.
Yeah.
ABCs.
Hey, can you, yeah, exactly, ABCs, say, can you respond, can you talk, what's your name? Is she breathing, does she have a pulse? That kind of stuff. So that's something I want to know with her. If she's just laying there on the floor unresponsive, is she breathing, does she have a pulse, does she talk to me? Like you said, the ABCs. So this is one where, ABCs are very important right off the bat because we don't know, is she unresponsive because she doesn't have a pulse, or what's going on? And in any patient with altered mental status, unresponsiveness, again, maybe not the very first thing you're going to do, but what's something you should check on her? Yeah. So that's part of the incident. Husband had came home and found her this way, called 911. Mental status, she's unresponsive. She does have cap refill, 2 to 4 seconds. It's a normal chest assessment. She is breathing over normal breath sounds. Procedures, so blood sugar was checked from a stretcher, 12 lead was at IV access, blood draw. She's diabetic. The blood sugar was 467. Really high blood sugar doesn't usually cause this, by the way. Low sugar will. High sugar, not so much. So the fact that she's unconscious out of it, you know, I wouldn't blame it on the high sugar. That's probably not what's doing it. Whatever caused her to be unconscious probably rose her sugar, caused her sugar to go up. Monitors placed with sinus Brady with runs of PVCs. And we'll look at that EKG and then rhythm sugar in a second. Again, 108 kilos. She's placed on the mega mover, 5-person carried out of the house, down the steps. I always feel bad. I always feel like with the bigger people, it's always down some kind of steps. It always seems that way. But
Never on ground level.
it really does seem
Never
like
on
that.
ground level.
Whenever I read through some runs you guys have, it's always like down steps.
Everybody lives on the third floor. It's always in between.
Oh shoot, I meant to take that out. Oh well, you'll get to see the EKG here in a second. So I was going to make you guys do the EKG, but move to the ambulance, 12 feet done with STEMI showing. Fax to the CRHED, call made advising a patient and estimated time of arrival. IV attempts in the left hand without success, but there was a successful IV in the right hand, 22 gauge. Placed on oxygen. Those were her vitals. Again, hypertensive, tachycardic, tachypnic. Guessing that's her sats on the 4 years launch.
Wait a minute, at first it said there's science Brady.
Yeah, you're right.
That's what you're-
Oh, I know why.
that's
You'll see.
So, yeah.
You'll see.
But I know.
The rest of it.
So, I wonder if the patient is having a sinus bradycardia and then having this going on. What do you think this could potentially be? Yeah. I got a clearer EKG here in a second, but so what does this look like to you? This at least to me, that looks like a normal sinus rhythm beat. And it looks like she's got an underlying slow rhythm of some sort, but then she's having this kind of stuff going on. What do you think those are? There's a couple of possibilities. I think I heard it.
Could be
Yeah, she could have, you know, VTAC with pulse. I mean, it's going to be little runs of VTAC. It could be triple to PVCs, if it's possible.
Could you just do PACs?
It could be PAs. It's hard to tell. I think these are wide, so with PACs they're normally narrow. But PVCs.
Oh, no, that's where our monitor brings it out anymore when you call that.
So here's a better picture. All right.
There you go, that's it.
So what do you think these are here?
That's it.
So yeah, these are right. So I think these are little runs of VTAC, is what I'm saying. And the reason why it was probably sinus Brady initially was you probably weren't having these signs of these episodes of VTAC. It was probably truly was. This is a sinus beat.
That's what you was actually feeling in the pulse,
Yeah.
is those 50 beats there.
Gotcha. Yeah. So that makes sense. Because with the VTAC, sometimes you'll feel it, sometimes you won't.
Yeah,
So-
versus monitor.
When you're reading an EKG like this to try to figure out, well, first of all, that was a good call to just go ahead and fax it to us to take a look at, because it's a difficult EKG to interpret. But when you're reading an EKG like this to try to figure out, is this a STEMI or not, I'd recommend trying to find normal beats, you know, in this madness of VTAC. But like this is a normal beat, that appears to be a normal beat, this appears to be a normal beat. So when you look at these normal beats, what do they look like to you? I mean, is there anything concerning with these?
Yeah. Elevation.
Yeah, you got ST elevation in 3 and AVF, and maybe a little bit in lead 2.
With reciprocal in 1.
Right, you got ST depression right here in lead 1,
And
ST
AVL.
depression and AVL. So yeah, you've got ST elevation in inferior leads with you know, reciprocal change in the lateral leads. These lateral leads, they show some T-wave inversions, but it's not as pronounced as one in AVL. So yeah, this person's having a STEMI with runs of VTAC, is what's going on. So with these runs of VTAC, again, it sounds like she is having a pulse, at least with the beats here. So I would not call this pulseless VTAC, because she has a pulse. I mean, you can feel it. Even though these aren't getting enough squeezed where you can feel it, feel the pulse, but you can feel these. So I wouldn't call it pulseless VTAC. But is there anything that you can give her to help with this if you'd identify that she's having runs of VTAC? Yeah. How would you give it? Again, you can feel the pulse. Yeah. I'd say 150 milligrams over 10 minutes, okay, is how I would do it. I don't think you need to, unless she's flat out coding, I don't think you need to push amiodarone. I mean, if she's coding, it'll just be 300 milligrams. But,
You know how they gave that in the ER? Only about 30 seconds.
did they really? Yeah, so a little overzealous than me, but that's all right. So I looked up on this patient, and she did well. She got a stent in her right coronary artery. Again, this is a good example of an inferior MI, and the most common blood vessel to be affected with an inferior MI is the right coronary artery. That's where hers was. So she got a stent, and it sounds like she made a good recovery, so it was a good save. But yeah, it's just a really interesting EKG because with right coronary artery or inferior infarcts, you can get this sinus bradycardia. It's actually pretty common, and oftentimes they'll drop their blood pressure too. Now, that wasn't an issue with her, but oftentimes they'll drop their blood pressure too. So I wasn't surprised when I heard that she was bradycardic, and you're probably right. It probably was more because these beats you just couldn't feel the pulse with, and you could only feel it with her native beats. But yeah, it's not uncommon for you to see a bradycardia with big ST elevations in the inferior veins with an RCA.
She stayed unconscious. She never did regain consciousness in the ER.
Did she not?
No. We finally got the IV on her. She got the last of the tube as we was pulling in the ER. Because I think it was only like 5 minutes from her residence to the hospital.
Gotcha. So yeah, she may not have been having enough blood
Dr.
flow to the
Wiesner,
brain to keep her conscious, but at least enough blood flow to where she made a recovery. Okay.
Yeah, Dr. Wiesner went ahead and gave her the amio, then did a cardioversion, and about 5 or 6 minutes later or so, she finally changed to just like a sinus tach rhythm.
Do you remember when she cardioverted, was she in sustained VTAC?
She was doing that when Dr. Wiesner cardioverted, and then when she went into it, I didn't really pay attention. I just know the rhythm changed to about 110, and just stayed there.
Okay. Yeah. It was no problem, but she recovered fine. She did okay. Oh, any other questions, comments on that one? Okay, case number 3, collapsed in the woods. So, 2025 dispatch to chest pain, possible heart. Went en route 2026, got there 2033, and the patient had been having chest pain per the wife. 56-year-old male, weighing approximately 114 kilos. Yeah, here again, it was like a long transport. Yes, but yeah, 114 kilos, complaining of chest pain, possible heart. The patient was found lying on the right side on a trail next to a pond. Skin is cold, dry, pale. His pupils are sluggish. He's unresponsive. What do we think about this guy? There's actually a couple things that can go on with him. So his wife said he'd been having chest pain. So yeah, he may have had like the big one, right? Big MI, just unconscious. Maybe he's in VFib or asystole.
You still have to, being out in the woods like that, you still have to take in the hypothermia component with it.
Yeah, I mean, he may be in severe hypothermia. He's outside, laying next to a pond. It's 8:30 at night.
Could be drunk.
Yeah,
This just happened
alcohol
a
makes
few
it
weeks
even
ago.
worse, by the way.
This just happened a couple weeks ago.
Yeah.
Yeah, I know about this one.
Was that witness or was it just somebody found
No,
it?
they found it.
Yeah, so we'll get there. So wife advised me he's been complaining of chest pain and they've been having trouble breathing since 4 o'clock. And I think they got there, what, 8:30? Yeah, so since 4 o'clock he'd been having chest pain. But he wanted to go back out to track a deer he had recently shot. So events prior to the incident, history of 2 prior MIs and high blood pressure. He was out hunting. He returned to the house around 4 o'clock after shooting a buck. He told his wife that he was having chest pain and some trouble breathing, but needed to track down the buck.
What's more important here?
Right.
See, that's important to find the deer.
Yeah. So 2 hours go by. He's out trying to find this buck, and the wife decides he's been gone for a couple hours. See if I can go out and find him. So she goes out looking for him in the woods. She heard him yelling out, but was having problems finding him because it was dark outside. She returned to the house and found her neighbor, landlord, and went back out looking for him, and they did find him, near that pond like we talked about earlier. 911 was called, and his wife advised that he is becoming less responsive while waiting for the ambulance.
That's a great feeling.
So, upon assessment of getting there, he's unresponsive. He's cold. Well, he's dry. That's good. He's cold, dry, pale. He is moaning. So he's moaning, and that's about it. Moaning and cold, unresponsive, or minimally responsive. So got him on a stretcher, got him on a cardiac monitor, did a 12 lead. The patient was assessed after we were taken back to him via an ATV. He was found unresponsive, cold, and bradycardic. He was quickly lifted onto the gator and taken back to the ambulance. He was lifted off the gator and placed on a cot with a backboard under him. He was secured to the cot with 3 straps, and side rails were raised. His clothes were cut off his upper body. Defib pads were applied. He was then placed on the monitor and started on high-flow oxygen via a non-rebreather. Vital signs and an EKG was acquired. IV was established in the left antecubital, 18 gauge, infusing fluid. This is one of those times that would have been a bad idea to put those warm packs around the fluid. But yeah, and giving fluid, IV secure, intact, and patent. Knew it, he started to really brady down. Thus, he was given atropine 1 milligram via IV. If you're below 86, see, this is the problem. You don't know the temperature, but if you're below 86, you can give atropine. I don't think you're going to. It's just probably not going to work. So you can give the atropine. If he was below 86, he probably wasn't going to respond at all to the atropine. But I don't disagree with the idea, because if it's a big, nasty MI and you're bradycardic and hypotensive, then you want to give atropine. But if you're really hypothermic and your temperature is below 86, it's a little bit of a risk to give atropine, because again, you don't want to irritate the heart, but you don't know what the temperature is. If you're above 90, there's a chance you'll respond to the atropine. So it's kind of a tough call, but I agree with it. I think it was a good idea, because it sounds like he was having a massive heart attack. If you're real bradycardic with a massive heart attack, atropine can sometimes help you out, get your pressure up. So he's given the atropine. Shortly after that, his heart rate improved, so it was a good call. Again, if he was horrifically, he's definitely severely hypothermic, but at least suspected to be. But had his temperature, core temperature, been below 87 or so, probably would have responded. So I can bet you right now his core body temperature is probably above 87, because he responded to the atropine. He had purposeful movement, tried to roll a couple of times, and was moaning. 12 lead was acquired, unrecognizable rhythm. It did show left bundle branch block, possible ST elevation. Could not discern due to artifact. We'll get to the EKG here in a second. Unable to get good pulse oximetry due to him being so cold. Contacted the ED via cell, advised patient's condition, treatment results, and estimate time of arrival. That's one of the rhythm strips. This one's kind of hard to read, but that's probably a beat there. That's probably a beat there. That's real slow. Okay, so here's another one. Again, more organized. This one, heart rate around 75. So improved. I don't know if that was before or after the atropine, but it's improved heart rate. You may guess it's after, but I'm not sure. Here's a 12 lead. What do you see on this 12 lead? There's a couple of interesting findings on it. So, one thing I see, what do you think about this peak here?
Is that the J-wave?
Yeah,
J-waves.
he's got J-waves. So he's pretty severely hypothermic to give you J-waves.
No way.
So that's the first kind of interesting finding. There's another J-wave there, another one there. And you're right, it can be tough because it can kind of look like a bundle branch block, right? I mean, it kind of does, but that's just J-waves. The other interesting finding is, and this is hard in a hypothermic EKG, but that's definite ST elevation. So here's the end of the J-wave, and here's his ST segment. Looks like this is his baseline, and the ST segment's way up here. Way up here at the ST segment, here's the baseline. Way up here at the ST segment, here's his baseline. Way up here. So he's having a, again, right here, there's his ST segment. So he's having like almost 5 millimeters of ST elevation. Actually, he's having over 5 millimeters of ST elevation here. About
Dr.
5.
Schneider,
Yeah.
would this been my one thought would have been to start warming him?
Oh yeah, most
Like in
definitely.
the back of the neck, in the groin, in that area.
Yeah, so you're exactly right. This is a guy that, I mean, his heart's really undergoing an insult right now. I mean, it's hypothermic, so it's going to be irritable to begin with, under stress. And on top of that, he's having a massive heart attack on top of it. So anything you can do to try to help out the heart, and any severely hypothermic patient, of course, I mean, you need to rewarm him. But even that much more so in this guy, because his heart is already undergoing an insult with a heart attack, and now it's also hypothermic. I mean, the stacks are really, the chips are really stacked against this guy, as far as
I guess
survival.
I'm just thinking that with what you gave us, my thought was to start getting him warm before giving him medicine. With what was said even at the very beginning.
Right, so this one's tricky. You're right. If it was straightforward hypothermia, that's exactly what I would say to do. If you have a pulse, I would say try to hold off on any kind of, if you've got a pulse, you basically just warming him up is the treatment, the best you can, to getting him to us. He's a little tricky because he has a pulse, but he's also having a major heart attack. A major heart attack can cause you to be bradycardic also. So it's hard to know, is it the severe hypothermia, which we know that's definitely playing a role because he's got J-waves, but is it the severe hypothermia that's causing him to be bradycardic, or is it the massive heart attack that's causing him to be bradycardic? If it's the massive heart attack causing him to be bradycardic, then atropine, it can help. I mean, it can raise your heart rate and get your blood pressure up if your blood pressure is low. So this is a really tricky, this one's really hard for anybody. I mean, you know, they had cardiologists in the ER debating on what to do with this guy. I mean, it was a really difficult set of events. So I don't think you'd have been wrong either way, I guess is the point.
That's just my thought process. It's, I guess, my years of experience.
If it was straightforward hypothermia, I'd agree with you. I'd say, if you've got a pulse, try to hold off on giving a bunch of medicines. Just warm him up.
I mean, I understand they said that he was having chest pain, but you've got a bradycardic, he's unresponsive, he's cold to the touch, yada, yada, yada. I would have thought warming up, starting.
I think they do that. I think that's done here in just a second. I think in a couple slides we talk about all the warming measures that they do. You know, when I look at this EKG, again, the J wave, the Osborne wave, that's one thing to jump out at me. And then just the huge ST elevations inferiorly, and then you see ST elevation here in V5 and, well, V6 kind of, can't really tell, but definitely got ST elevation in V5. And then he's got ST depression here in V1 and V2. So when you have ST elevation in these 3 leads, these 2 leads, and then you have depression in these 2, that's not something I expect you to know, but that means your whole right ventricle is infarcting. Your whole right ventricle is like I said, you've got a blockage in a very first portion of your right coronary artery. So the whole right ventricle is infarcting. Okay. So this is a major, massive heart attack this guy's having.
So, could the
question be that the cold is also trying to keep the heart alive because it's slowing it down?
So in this instance, I would say that the cold is probably doing more harm than good. But you bring up a good point, because when he eventually codes, and he will, spoiler alert, finish the codes. You know, if you get him back, you're actually going to not want to bring him back to completely normal temperature. They're actually going to target him back at 95 degrees. So, but you're right, there is some benefit to some hypothermia, but not this degree of hypothermia. This is too much. So, there's the initial blood pressure, heart rate, respiratory rate. I'm going to guess that's after the atropine. It's kind of hard to tell, but there was an increase in blood pressure response. So while in the ER, so the guy survived transport to the ER and still had a pulse, and actually the blood pressure had improved. He was hypothermic. His temperature upon arrival was 31.2. So again, it makes sense that the atropine worked because he was greater than 86. Usually if you're below 86, atropine's not going to work. He was 88, so it kind of makes sense that you got some response to it. The bear hugger was applied, warm body fluids via hotline, patient was intubated. Temperature actually raised to 32.3 within about 30 minutes, so he'd gotten up to a little over 90 degrees. I don't know exactly what that is, but a little over 90 degrees. So that was the treatment for the hypothermia in the ER. Every physician's going to do things a little different. Other things that they could have done would be warm, humidified air or oxygen, something else that they could have done to kind of warm up the core. You know, the bear hugger was a good idea. I don't know what temperature that hotline is. Again, I just crank that thing up as high as I'll go. And I would do D5 almost anything if it was me, just because they may need a little bit of sugar. And then if you were, like I said, if you were going in and out of arrhythmias and your temperature was less than 86, then I'd be strongly considering doing chest tubes in this guy and giving him warm fluids to the chest. So there's the hypothermia component, then you've got the STEMI component. So the patient's obviously having an inferior MI. That's actually a little bit of an understatement. He's having a right ventricular infarct MI. His troponins 13.5. Which troponin's one of those cardiac enzyme markers, and that's really high. While in the ER, he starts becoming bradycardic. His heart rate's 26. This is his blood pressure, 47/29. And this is where it became difficult because, again, you want to treat the heart rate and the blood pressure, but you want to be careful because the heart is still irritable because it's cold. It's a tough call to make, basically. So the cath lab was activated, and the cardiologist decides the patient's just not stable enough to go to the cath lab. So the decision's made to fly the patient to Methodist. The helicopter crew arrives, and shortly after arrival, the patient codes, and his rhythm goes into asystole. Was it the hypothermia that did it? Was it the MI? It was probably more the MI than the hypothermia. Because usually if your temperature's above 86, you start to get out of that danger zone of spontaneously going into fatal arrhythmias. But it's possible. It's just, you usually start to get out of that risk category. But anyway, at any rate, he goes into asystole. They try to revive this guy for a good 20-30 minutes at least, and it just was not successful. He ends up passing away. I think he probably more passed away from his massive right ventricular infarct heart attack that he'd been having for the past 5 hours or so. Yeah. But at any rate, it was one that left everyone very disheartened because it was like, gosh, you would make the right decisions, not doing this or doing this. It was just a really complicated case because of the hypothermia that was on top of it. It made it really tough.
I guess what's kicking my butt about this is how that guy gets so cold. It hasn't been that cold.
2 hours.
I mean, what was he out there in his underwear?
I don't know.
Laying on the ground or something? I mean,
If he had been drinking,
Laying next to the water is not going to help him.
What was
Be
it?
cold.
What was the price of Grayson?
How'd he get so cold, so fast? He was only gone for a couple hours. How'd he get down to that, like, stuck in the Arctic kind of cold type of thing, what I think of?
Okay, well, this is my line.
Okay.
He's laying on the ground.
Well, that explains a lot. I understand he's laying on the ground. And He's not couldn't find naked.
Yeah.
And it's wet. If that ground's wet, the conduction becomes greater on.
And the wind was blowing across the lake.
Yeah.
There you go.
Oh, the wind.
That'll get you.
I thought this was a pond. That's something
Well,
like
it's
a
still,
pond.
you was circling around in, with that pond. Yeah, it's not really a lake, it was a pond. But the wind was blowing, it blew, I don't remember how cold it
Was
was.
he, did he have a coat on? Did he have a hat
It
on?
wasn't that thick of a winter, a hunting coat.
Golly, I'm just blown
Do you know
away.
if you've been drinking?
I would guess he
'Cause you'll lose
probably,
your temperature, you'll lose your body heat a lot faster.
He's not a drinker.
I would say he probably was diaphoretic during this
Oh, that's good
episode
stuff,
as
too.
well,
Yeah.
so
So he's
he's,
soaking wet. right?
he's gonna lose body
Yeah, he
temperature
was
fast
dry.
from that.
Yeah, that's a good point, probably, right?
Well, then, and he had 2 previous heart attacks, right?
Yeah.
So he's not.
So he ought to know better.
I guess, I can't get this out of my head. Cath lab activated, patient not stable enough for
Yeah,
cath,
I didn't quite
and
understand that
decides to
myself.
fly out. What's gonna make him more stable flying out?
Take a 20-minute flight.
Passing the buck.
I think that I didn't quite understand that part myself, I'll be honest with you. But I think the thought process was, our cardiologist doesn't feel comfortable enough taking care of this patient. I need to get him to a cardiologist who does.
They think it bypass?
Yeah, that was the thought process, honestly.
I mean, I know this guy isn't, you know, able to say anything, but, you know, I think I need to write myself a little piece of paper, hey, you know, give it a try, you know, just, you know, I don't care how unstable I am, just give it a shot, you know.
What am I gonna do?
That just struck me as funny.
So, you know, it's always easy to play like
You're
we're
right,
the
Tom.
quarterback, but I spoke with the physician about this one because she asked me to kind of review it and see if there's anything different that I would have done. And I kind of went over a few things. I mean, probably one thing I would have done, and it probably wouldn't have made a difference, but if the cardiologist had told me, hey, this patient's not a cath lab candidate, I probably would have said, then can I push TPA? If you're not going to take him to the cath lab, can I give him TPA? Again, I don't know, it probably wouldn't have made a difference,
It was his day.
but that's, yeah, I think it probably was. But that's the one thing I would have asked. And again, I don't think TPA is contraindicated in hypothermia, but that hypothermia makes things a lot difficult. It's just, he was really unstable, and it was probably more the heart attack than anything making him that unstable. If they're not going to take him to cath lab, I mean, and really it would have been nice if the cardiologist had kind of, you know, really would have been the one to kind of guide that direction. But basically, what was told to me was that the cardiologist said, hey, I just don't think he's stable enough to survive being on the table. You need to stabilize this hypothermia first, see if that improves his vitals, and then I'll take him to cath lab. And the physician said, I don't feel comfortable with this. He's way too critical. I need to get him to a facility that feels comfortable taking care of this guy's heart along with his hypothermia, because this physician doesn't feel comfortable. So it was just a really difficult patient to know exactly what the right thing to do was. And in all likelihood, all roads were going to lead to cardiac arrest, most likely, with this guy.
Doc, is there any, when it comes to flying a hypothermia patient versus ground transport, is there anything special to consider there? Or just kind of do your, whatever normal thing you would do anyway?
I can't think of any. It was a good example of severe hypothermia, but it was also a good example of an MI. So the first case was mild hypothermia, the second case was MI, and then the third case kind of combined the two. So I saw it. You had
That's probably being so high like that. This has been going on a while.
right, yeah, because you don't usually get a rise in troponin for maybe about an hour, half hour, an hour. And you'll start to see a rise in troponin. So the fact that his troponin is 13.5, he's been infarcting for a while. Probably for 5 hours, honestly. For sure.
Define the deer.
I always feel bad because I honestly ask that question because like my mind just thinks that I want to know, you know, and I don't know. Nobody knew.
Another deer pissed on him.
That's why he got so cold, so that's why he was so pissed.
So that's all I got. Those are the 3 cases.
Deer limped over there on the crutch.
You're gonna